Welcome to AETCM, the emergency medicine channel. Today let us discuss about metabolic acidosis and one important acidosis, that is diabetic ketoacidosis management. You can see the acid-base balance here. Our acid-base balance is maintained by our lungs and kidneys. So I can see the formula here. pH indicates hydrogen ion concentration. pH is inversely reversed to hydrogen plus ion concentration. Hydrogen ion increases, then you can see the pH decreases. Hydrogen ion decreases, pH increases. pH is maintained in between 7.35 and 7.45. This is due to mainly a buffering system in between respiratory and renal system. So this buffering system maintains our pH in normal limits. If it is less than 7.35, it is acidosis. More than 7.45, it is alkalosis. Extreme acidosis and extreme alkalosis can produce permanent damage to our organs, and it can lead to death. Now, metabolic acidosis is considered as when there is primary fall in bicarbonate level. That is metabolic acidosis. Due to any reason bicarbonate level in our body is falling, then it is metabolic acidosis. And that may lead to compensatory reduction in carbon dioxide. There is a compensation to maintain the pH in between normal limits. So you can see metabolic acidosis means primarily bicarbonate reduces, pH also reduces, that will lead to acidotic pH. Then initially carbon dioxide levels are normal, then patient will have hyperventilation and carbon dioxide will be removed from our body. That will lead to hypocarbia and the compensation occurs. You can see the compensation formula for metabolic acidosis here. For given bicarbonate, we can calculate the expected CO2 levels. 1.5 into bicarbonate plus 8 will give the corrected carbon dioxide level in that patient. So that is a compensation for metabolic acidosis. Other formulas also given here. We are not discussing that, so we will not go to that type of formulas here. Metabolic acidosis, we can calculate the pH, PaCO2, that is 1.5 into bicarbonate in plus 8. That will give the carbon dioxide level. Metabolic acidosis is accumulation, acid accumulation due to increased acid production or acid ingestion, decreased acid excretion, gastrointestinal or renal bicarbonate loss. So either acid is produced more or decreased acid excretion levels or increased bicarbonate loss. These are the major causes for metabolic acidosis. You can see here increased production of metabolic acids like ketoacidosis, diabetic ketoacidosis, alcoholic ketoacidosis and lactic acidosis. Loss of base, that is bicarbonate loss through GIT in diarrhea, through kidney in proximal renal tubular acidosis. Failure of hydrogen ion excretion by kidneys, renal failure and distal RTA. Ingestion of potential acids, salicylic acid poisoning, NH4Cl poisoning. Now, anion gap acidosis is a type of acidosis where there is a difference between sum of routinely measured cations minus routinely measured anions in the blood can be seen. So the gap will be more in high anion gap acidosis. Anion gap can be calculated by measured anions like sodium plus potassium minus measured anions, that is chloride plus bicarbonate. So cations, that is measured, minus anions which is measured, will give you the difference between these two, or it can give the unusual cation or anion in our blood. That can give the anion gap. So high anion gap metabolic acidosis reasons are decay, accumulation of ketones, they are unmeasured, starvation ketosis, accumulation of ketones, lactic acidosis, tissue hypoxia or chronic liver disease, renal failure, accumulation of organic acid, increased oxygenous acid, aspirin, accumulation of salicylates, methanol poisoning, accumulation of formate, ethylene glycol poisoning, accumulation of glycolate oxalate. These are the causes for high anion gap metabolic acidosis. So you can remember high anion gap metabolic acidosis like this: mud piles, that's a mnemonic; methanol, uremia, diabetic ketoacidosis, fenformin poisoning. That is, nowadays it is very rare, fenformin poisoning. Metformin is there, but metformin only higher doses it can produce acidosis. Iron or INH toxicity, lactic acidosis, ethylene glycol, that's a toxic alcohol poisoning, salicylate or aspirin poisoning, starvation, ketoacidosis. So these are the common causes for high anion gap metabolic acidosis. We have seen the formula for high anion gap metabolic acidosis. Now, normal anion gap metabolic acidosis you can get in bicarbonate losses like GI tract loss, renal loss like renal tubular acidosis or diarrhea, acid gain from metabolized to hydrochloric acid, impaired renal NH4 excretion, CKD, that is chronic kidney disease, distal RTA, proximal RTA, organic acidemia with rapid excretion of acid anion. So these are the common causes for normal anion gap metabolic acidosis. So we can get normal anion gap metabolic acidosis or high anion gap metabolic acidosis. Treatment for acidosis is almost similar, but when we diagnose a particular reason, the treatment for that is different in each category. So if you know about the causes for normal anion gap acidosis or high anion gap acidosis, it will be easy to treat the cause for the acidosis. Now you can see the causes for normal anion gap metabolic acidosis mnemonic, that is saline infusion, hyperchloremic acidosis. But you can see when you are giving large volume of normal saline, you can see this type of acidosis, but that is not clinically significant. We can see the acidosis in ABG, but it will not create any clinical problem in the patient. Exogenous acids like ammonium chloride, hydrochloric acid, not very common. Carbonic anhydrase inhibitor overdose, that is acetazolamide. Ureteric diversion, bicarbonate loss can occur there. Diarrhea, bicarbonate loss can occur there. Hypoaldosteronism, hyperchloremic metabolic acidosis can occur, like large volume overload, you can get same problem. Here also you can get same problem. Adrenal insufficiency, intestinal fistula, there also you can get excessive bicarbonate loss. Renal tubular acidosis. So these are the common causes for normal anion gap metabolic acidosis. Now whenever the patient is having acidosis, we have seen that lungs will try to compensate that with washout of carbon dioxide. Patient will try to breathe more, so the carbon dioxide will be washed out, carbon dioxide levels will reduce, carbonic acid will reduce, that will correct the pH. Okay, so that for that compensation, patient will breathe very deep and regular rapid sighing respiration. The respiratory center in the brainstem will be stimulated due to metabolic acidosis. So one of the common cause for tachypnea in emergency room is metabolic acidosis. Hypotension can occur, arrhythmias can occur, headache, confusion, coma can occur. Now remember the clinical features like Kussmaul. So Kussmaul breathing you can get in patient who is having metabolic acidosis, and the clinical causes for Kussmaul breathing can be remembered like this: ketosis, that is diabetic ketosis; uremic acidosis, renal failure induces uremia; starvation ketosis; methanol or ethylene glycol poisoning, that is toxic alcohol poisoning; aspirin poisoning; lactic acidosis. So Kussmaul breathing is due to metabolic acidosis. It is a compensatory mechanism of our body. Now, whenever we get acidosis in any patient, we have to do first a blood sugar, because diabetic ketoacidosis is very common, which can present with high anion gap metabolic acidosis. Serum potassium can be done, creatinine for renal failure, urea for renal failure, sodium chloride can be done because hyperchloremic acidosis we have seen that, lactate to rule out lactic acidosis, salicylate levels if the patient has taken aspirin tablets, multiple aspirin tablets, you can develop salicylate overdose. Urinary pH, urinary ketones. So urinary pH is done for renal tubular acidosis, urine ketones for diabetic ketoacidosis. Ideally serum ketones are better than urine ketones in DKA. ABG should be done. Anion gap should be calculated. We have seen the formula in the previous slides. That will tell you whether the problem is high anion gap metabolic acidosis or normal anion gap metabolic acidosis. Now there is one concept called as delta gap. If you read about ECG, read about more about ABG, you can see delta gap. Delta gap can be calculated with anion gap minus 10 by 24 minus bicarbonate. A value less than 1 indicate mixed metabolic acidosis. Example, a non-anion gap acidosis and a high anion gap acidosis. So delta gap can be calculated in DKA. So you can sometimes get a metabolic acidosis due to diabetic ketoacidosis with hyperchloremic acidosis because of overcorrection of fluid. A value more than 1.6 indicates mixed metabolic acidosis and metabolic alkalosis. So we can get multiple problems in emergency room. So these investigations may be helpful to find out the cause for the metabolic acidosis, and when there is mixed acid base disorders, these delta gap like formulas may be helpful in emergency room. Now base excess, base deficit, you can see in your ABG values. Base excess or base deficit of plus or minus 2 milligrams is normal. A positive number is called as base excess, that indicates metabolic alkalosis. A negative number called as base deficit, that indicates metabolic acidosis. Severe metabolic acidosis is associated with a base deficit of less or minus 10 milligrams per liter. So severe metabolic acidosis can lead to base deficit more than minus 10. Now another important investigation is osmolar gap, that has to be calculated. Osmolar gap is the difference between measured serum osmolality and calculated serum osmolality. So calculated serum osmolality you will get from the lab, measured you will get from the lab. Calculated we have to calculate by 2 into sodium plus glucose by 18 plus blood urea nitrogen by 2.8. So that can be calculated with the formula. Normal osmolarity is 275 to 290 milliosmolar per kg. There is a difference between measured and calculated osmolarity, that is called as osmolar gap. Osmolar gap indicates toxic alcohol ingestion. So in a patient who is having high anion gap metabolic acidosis, if you are getting in an osmolar gap, high osmolar gap, then you suspect toxic alcohol ingestion. So you can see the elevated osmolar gap more than 15. The common causes are routine alcohol itself can produce high osmolar gap, ethanol, methanol, ethylene glycol, mannitol, hypertriglyceridemia, hyperammonemia like macroglobulinemia. All these things you can get elevated osmolar gap. So osmolar gap acidosis, always suspect toxic alcohol ingestion. That is very, very important. Now this is the approach towards ABG report, EC approach towards ABG report. If the pH is less than 7.35, then we suspect acidosis. In metabolic acidosis, bicarbonate is low, that leads to reduced pH, and To compensate that, carbon dioxide also will be reduced. For that, patient will be in a hyperventilation state. We have to calculate the anion gap to know whether it is high anion gap metabolic acidosis or low anion gap metabolic acidosis. Sodium minus bicarbonate plus chloride, that will give you anion gap. Normal anion gap is 8 to 12. If it is high, we have to always suspect decay, lactic acidosis, renal failure, methanol poisoning, ethylene glycol poisoning. There you have to see what is the osmolar gap. Osmolar gap mostly indicates a toxic alcohol ingestion. Other causes also there, we have seen in that previous slides. Now the treatment, when we discuss about the treatment, the most important treatment in most of the acidosis is IV fluids that we'll see in diabetic ketoacidosis, and we have to treat the underlying cause. We have to correct the electrolyte imbalances like hypokalemia, hyponatremia, all these things. Hemodialysis may be needed in patients with renal failure, ethylene glycol toxicity, methanol toxicity, salicylate poisoning toxicity. Alkali therapy is not indicated in all types of metabolic acidosis. Rarely it is indicated when the pH is less than 7.1 or patient who is having cardiac failure. There we can start sodium bicarbonate. So sodium bicarbonate is not a routine treatment for any types of acidosis. That is only in selected patients we give sodium bicarbonate with caution. Now you can see the treatment of DKA, that is one of the most common type of acidosis in emergency room. We can see the treatment protocol. We have to take care of airway, breathing, circulation, and we have to rule out diabetic history and blood sugar values, like you have to do a glucometer RBS immediately. Then electrolytes, important electrolytes in DKA is potassium deficiency can be there in diabetic patients. Sodium also can be low. Then take an ABG that shows high anion gap metabolic acidosis. Sometimes lactic acidosis can be associated with that. Fluid management is very, very important. We have to start IV normal saline, because normal saline can replace the intravascular volume initially. Most of the patients with DKA requires 6 liters of fluid in 24 hours. If it is HHS, hyperosmolar coma, then they require 8 to 9 liters of fluid. Glucose monitoring must be done in all patients with DKA hourly. Hypokalemia should be managed, because most of the patients who is having diabetes with DKA can have hypokalemia. On treatment, if we start insulin before correcting the potassium, patient can develop sometimes severe hypokalemia because of shift hypokalemia. Then only we can start insulin infusion. So that should be started only after correcting the hypokalemia. JVP should be monitored in patients who is having cardiac failure. Otherwise, routine JVP or CVP monitoring is not required in DKA. Patient who is having fluid overloaded condition like renal failure or cardiac failure, this is required. Ketone bodies can be done in serum in DKA patients. Urine ketone bodies are not good choice in DKA, because sometimes ketone bodies cannot be seen in urine who is having renal disorder. Insulin infusion should be continued. Lower dose of insulin infusion should be continued till the patient is stable and is ready to take oral feeds. And we have to monitor blood pressure, pulse, oxygen saturation, mental status, fluid status, intake output chart, all these things in our ICU. Now fluid replacement, we already discussed, patient may require nearly 6 to 7 liters of fluid. So initially normal saline can be started 1 liter in first 30 minutes, 1 liter over next 1 hour, next 1 liter over next 1 hour, 1 liter over next 2 hours, 1 more liter after next 2 to 4 hours. So we are giving 4 liters in first 2 to 4 hours. Then we have to continue another 2 liter over 24 hours. If the patient develops hypoglycemia or if the sugars are less than 250, you can switch to saline contains dextrose or 5% dextrose to be continued. So some patients with rapid correction of sugars can develop brain edema or cerebral edema, especially in children. So that has to be taken care of. Fluid requirement in DK is 6 liters in 24 hours. In HHS it is 8 liters in 24 hours. Once the fluid is started, then we have to look for the potassium, because potassium is the most important electrolytes in DKA, which can be reduced initially because of high blood sugar. Shift will occur, and when we start insulin, again the shift will aggravate and patient can develop severe hypokalemia, muscle weakness, arrhythmias and all. So before correcting the blood sugar with insulin, we have to start potassium correction. If the potassium is less than 3.5, give 40 millicurrents in peripheral line, and if the potassium is 3.5 to 5 millicurrents, give 20 millicurrents. Then only start insulin infusion, and ongoing potassium deficiency also should be corrected. So we have discussed about one of the most important problem in emergency room, that is metabolic acidosis. There are large number of causes for metabolic acidosis. What we understand is one of the common cause for tachypnea in emergency room is metabolic acidosis. It can be high anion gap metabolic acidosis, or it can be a normal anion gap metabolic acidosis. To find out this type of things, we can use the formula we discussed in the previous slides. The identification of cause for metabolic acidosis is very, very important, because then only we can treat the cause for the metabolic acidosis. Treatment of metabolic acidosis, mostly it is IV fluids, and soda bicarb should be used with caution, because sometimes it can produce adverse effects, because it contains sodium bicarbonate that contains high levels of sodium and alkali. It can sometimes create problem in emergency room. Thank you.